Good evening. This evening I'm going to be talking about something which causes enormous concern to anybody who thinks they might have the diagnosis, and that is cancer. And for any doctors in the audience, you will know that one of the worst conversations you have begins with the phrase, "You have cancer." And you can see someone in front of you freezing. And the rest of what you say ceases to matter for a very long time. Cancer is, however, and what is surprising about this is that if you talk about things that are equally dangerous to their health, like, for example, heart disease, the same kind of reaction does not happen. And what they're seeing flashing in front of their eyes is the idea that they're going to have an appalling treatment which will be painful and debilitating and undignified, and then they're going to die. That is very much the way that people tend to view the diagnosis, even in this day and age. If we go back in time to Sir Thomas Gresham's time, because cancer is primarily a disease of old age, it was not very common, actually, as a cause of death and disability at that stage. But descriptions of cancer go back millennia. Cancer is not, despite what some people may think, a new disease. It is much more common because other causes of disease that kill you earlier in your life have now disappeared or are disappearing. So if you look at Sir Thomas Gresham's time, around the time this college was founded, there were wide numbers of theories around cancer, including, for example, that cancer was infectious. And a major proponent of this particular theory was Dr. Tulp, who is memorably painted by Rembrandt here, who first introduced people to the idea that cancer might be contagious. At that point, really, the opportunities for treating cancer were extremely limited. And there were attempts to treat it surgically. I've given a quotation here from the famous Scottish surgeon John Hunter, that if you had a small superficial cancer that was relatively easy to identify, people could then try and remove it surgically. But surgery was, of course, a dangerous and extraordinarily unpleasant thing to have in that era. Now, if we look at the overall mortality rates in the UK, you might think that cancer has gone nowhere in the last few decades. And this is a slide I've shown previously to demonstrate the extraordinary advances there have been in cardiovascular disease over the last 40 years. So infectious diseases really disappeared as a major cause of mortality in high-income countries over 100 years ago. And the cardiovascular diseases, which really took over to dominate causes of mortality, have been disappearing very steadily. And it looks as if cancer is essentially on a flat trajectory. So in this talk, I'm going to consider these issues. I'm going to talk about trends in cancer survival, diagnosis, surgery, radiotherapy, chemotherapy, hormone therapy, immunotherapy. These are getting steadily more modern in terms of the way we approach them. And finally, some points about policy and the future. Looking at the 10 leading causes of deaths in females over the last decade, you see really quite substantial changes, as you would expect from the previous data, on cerebrovascular diseases and stroke. These have been decreasing over the last decade a great deal. Dementia has increased in a sense to take that place, and we've talked about dementia last term. But the thing which appears not to have changed very much is the malignant neoplasms, which are the cancers which I've highlighted with the arrows on the left. That, however, would be a mistake. Now, I'm going to start off here with 1-year cancer survival. And if you look at the majority of cancers now, the great majority of people, over 75% for many of them, will be alive and having a reasonable quality of life a year later. But to be alive a year later is a relatively modest ambition. So I'm going to show the data for how many people will be alive 10 years later, which I think is a much more important question. And what I'm going to go through, and I'm going through these relatively quickly. I'll come on to the how this happened, but this is what has happened. I'm going to go through a number of cancers and what has happened over the last 40 years in terms of their 10-year survival over time. Now, these data have to be interpreted slightly carefully because diagnostic criteria change over time. But these are the best guess, and I'm using either ONS or Cancer Research UK data because I want to have a sort of relatively stable set. On the left here, we have prostate cancer. If you went back 40 years, the great majority of people would have died within 10 years. Only 25% survived. At this point, over 85%, I would normally expect, who were diagnosed with prostate cancer today, would be alive 10 years later. And if you're alive 10 years later, it is very unlikely this cancer is going to cause you major problems in the future. On the right, the equivalent disease, in a sense, one could say, breast cancer in women. The survival was slightly better 40 years ago than it was for prostate. It has improved slightly more slowly, but you're still at the situation where you would expect around about 80% of people to be alive 10 years later and, for practical purposes, cancer-free. Really quite substantial changes. Some cancers, such as testicular cancer, here on the left, have now got to the point where virtually nobody will die. It's incredibly rare to die from this disease. The treatment, which is a combination of surgery and chemotherapy, sometimes radiotherapy, is highly effective. But the equivalent disease in women, ovarian cancer, there is, although in some improvement, still a significant mortality rate, with the majority of people dying within 10 years. Now, the difference between these two is not that ovarian cancer is massively more difficult to treat, but that it is massively more difficult to diagnose. So that by the time someone actually realizes they've got it, the disease is much further advanced. Testicular cancer people pick up at a fairly early stage. And just a few other important diseases. Bowel cancer, again, we've now got to the point where the majority of people will be alive 10 years later after diagnosis. Melanoma, we're at the situation where around 90% of people will be alive 10 years later. Extraordinary improvements on what we would have seen 30 years ago. And then some diseases which have improved a lot among the lymphoproliferative diseases, the diseases of the blood, like Hodgkin lymphoma on the left, but some like leukemia, which are still improving, although some leukemias, the outlook is now extremely good, and I'll come on to one of those later on. But it is important to recognize that there are some cancers where this remarkable improvement has not yet started. And the example I've given here is lung cancer. And I've chosen the 1-year survival to demonstrate there have been improvements in survival. But if you look at the 10-year survival for lung cancer, it is still depressingly small. But, and this is an important thing which I'll come on to the next lecture, this is a disease which is almost entirely preventable. So just to summarize some of the changes we've had over this period, these are all the cancers. The left side of the arrow is where they were in 1971, and the right side of the arrow is roughly where they are now. And at the far right of the graph is 100% survival. The far left is no survival. And as you can see, in virtually all of them, there has been substantial improvement, but not all. And in some of them, it is now essentially a disease which you'd be very unlucky to die from, but there are some where it remains a potentially very serious cause of mortality. So finishing this off, when we come on to the causes of mortality, and here I've chosen to use the male data in the UK as an example of a wealthy country. If you look at cancers, the big burden of mortality is the biggest burden by far, actually, is lung cancer. And the reason for that, it is both common and extremely likely to kill you within a year or slightly more. Whereas some of the other cancers are less common but are highly dangerous, or they are very, very common, like prostate cancer, but not very dangerous after treatment relative to what they were 30 years ago. So the mortality we see in the UK is a combination of the incidence, how common the cancer is, and the survival, how well we can treat it. This talk, I'm going to be talking entirely about the survival, how you treat it. In the next talk, I'll be talking about how you actually prevent it. Now, the reason I've put this into a series on the bold aims of our generation in medicine is because cancer has something which is very different from, for example, infectious diseases. And that is the thing which is going wrong is your own cells. And that makes the treatment of cancer substantially more difficult than if, for example, you've got an infection where they are a completely different organism that you're dealing with. And so the combination that you have to achieve is both to kill or remove or control the cancer, but also not to excessively damage your normal tissues, which you depend on for a good, happy, and healthy life. And the rest of this talk is really about how we do that. Now, the most important thing initially is to get the diagnosis right, to get it early, and to be able to tell exactly where the cancer is. So I'm going to talk a bit about the advances we've had in diagnosis, which are continuing all the time. And the reason this is important is there is a very clear linkage between how early a cancer is diagnosed and how good the survival will be later on. So this, for example, is the different stages of bowel cancer. The left-hand one, the stage 1 disease, which is a polyp on the bowel, not going into the wall. The survival for that will be really excellent with modern treatment. But as you steadily get through to a bowel cancer that's got large enough to get right the way through the wall and it's invading blood vessels, then the survival, even with the optimal management, will be substantially worse. Clearly, the key, therefore, is to find the cancer early and treat it at a point when it is almost entirely likely to be treatable, rather than finding it later. And what has helped us have been a series of significant improvements in our diagnosis, many of them based on better technology, but not all of them. The first really big advance was X-rays, straight, plain X-rays. Inevitably, the cancers I'm showing you are very large cancers because these are ones I want you to be able to see in the hall. Clearly, the aim is to diagnose things that are considerably smaller than this. So on the left, you have a plain X-ray of a lung cancer. And on the right, you have someone who has got an obstruction of the bowel due to a bowel cancer. This is very old technology now. What has improved is our capacity to have much better delineation of cancer and being able to see bits of the body which you simply cannot see with ordinary X-rays. So on the left, the first big advance really was CT scanning. And then following on from that, and CT and MRI are things where the UK has taken a very major lead in the technology on this, is MRI scanning. These are both cancers in the same gentleman. They're the same cancer, but as you can see, it is a lot easier to see on the right than on the left. And for those who are interested in radiology, what you see is a lot of inflammation around the cancer as well as the cancer itself in these scans. So you can see significant improvements with that. And then more recent still are new methods of nuclear medicine where you can label short-acting radio-labeled tracers, and then you can scan people for where they're being taken up in the body. And because cancer cells are extremely active, you can then see areas that light up in bits of the body, and you can say the cancer has spread to those areas. So this is someone who has had some spread of cancer from the bowel into the liver, which you would be difficult to see under other circumstances. So our improvements in radiology have allowed us both to diagnose cancer earlier, to diagnose cancer in places that we didn't see it before, but also to know exactly where it is, so that if you remove it or you want to have radiotherapy, you're going to accurately hit the bits which are cancerous and hopefully not remove or kill off the bits which are not. So making exactly working out where the cancer is really important. Another technological advance, which again is getting better the whole time, is endoscopy. This is cameras on the end of flexible tubes for practical purposes. And we can now get these into incredibly small holes anywhere in the body. So you can have colonoscopy, where you look into the lower gut. You can have gastroscopy, where you look into the stomach. You can have bronchoscopy, where you look into the lung. Cystoscopy, where you look into the bladder, and a variety of other methods, some of which are still in development. The point about these is, firstly, you can directly visualize a cancer. Secondly, you can take a biopsy, which you can look at subsequently under a microscope, which will give you a better diagnosis. And thirdly, for early cancers, like this bowel polyp you see here, you can actually treat it at the same time. You can simply remove it endoscopically. It's a quick, very effective procedure, which you can do early in disease. So these are enormous advances diagnostically, which are improving our ability to get cancers early and to avoid damaging actually normal tissue. We also are getting better at the histological diagnosis. That's the diagnosis down the microscope once a biopsy is being taken. And again, the more accurate you can be, the more you can be certain what cancer you're dealing with, and you can make sure you take out what you need or kill what you need and don't kill anything else. And we've moved from an ability simply to be able to diagnose cancer, as, for example, on this scan on the left, to one where we can actually look for particular markers on the cancer which tell us which drugs the cancer will respond to. So this one happens to be markers of hormone receptors in breast cancer. This will tell you whether you can take tamoxifen effectively or not. So these improvements are leading to much more targeted therapy, both in terms of physical targeting, but also in terms of drug targeting. So that is a bit about the epidemiology and a bit about survival and a bit about the diagnosis. How about treatment? The earliest form of treatment for cancer, clearly, was surgery. And surgery remains the best treatment for small, localized, solid tumours. Essentially, if you can remove them completely, remove all the cancer cells, that's the end of the problem. So surgery was and is incredibly important. The key enabling sciences for surgery were obviously diagnosis, but also, importantly, anesthesia and antisepsis. The illustrations I've given you here are from surgery for tongue cancer in 1946. This would probably have been done without anesthesia. Just imagine what that would have been like. So being able to do major operations, you had to have anesthetics first. Cutting things out is relatively straightforward, although doing it in a very measured way is much more difficult. But doing it to someone who's actually awake and feeling pain, that's a completely different matter, obviously. Surgery, I think, is often seen as a relatively old-fashioned discipline, and in one sense it is, but it is enormously improving in terms of cancer surgery at the moment. This is partly because of concentration of expertise. As with every trade and every profession, doing something very often makes you better at it. Therefore, getting people who are highly concentrated leads to better outcomes. We're getting much better, and I'll come back to this, at working out what is the best combination of surgery, radiotherapy, chemotherapy, and other drug treatments. But there's also some specific advances. For example, endoscopic and keyhole surgery. I've demonstrated some of the simple endoscopic surgery earlier on. And, for example, this is robot-assisted surgery for prostate cancer. The surgeon is the gentleman on your right, quite some distance from the patient, who is the gentleman you can't see under the green drapes there. And because you're using a robot and a lot of magnification, it's possible to have a much more exact removal, meaning you remove everything you want to remove and you don't remove anything that you don't. It doesn't necessarily improve prognosis, but it may well improve your quality of life afterwards because less damage, non-damaged tissue has been removed. So these advances are meaning that even the oldest method of treating cancer are improving the whole time. As a physician and as a human being, I strongly believe that less surgery is better than more surgery, and no surgery is best of all. And surgery, one of the things that have been happening recently is trials to see how little surgery you can get away with without actually doing any damage to cancer survival. And I've given two examples here. One is a very old study, and I've chosen an old study because this demonstrates the survival continues for a very long time, comparing relatively breast-preserving surgery with mastectomy. And what you can see is the difference in outcome is absolutely minimal over time. Now, if we were starting now, the survival would be much better than you see in that graph. That's looking that way because these are data from 30 years ago. But conserving surgery is not more dangerous if it's done in a controlled way. And on the right, You may think, what am I trying to show you on? That's all I'm showing is a straight line. That's deliberate. This is a study that was published only about 6 weeks ago, very important study in my view, which took people with localized prostate cancer and randomized them to get surgery, radiotherapy, or just active watching. And the survival for almost all of them was complete, and there was no difference between those three. Now, this doesn't mean all prostate cancer shouldn't be treated, absolutely not, but it means that some prostate cancers are sufficiently small and localized, you can just watch them and they will not progress, which saves you a lot of unnecessary concern and potential after effects. And then have been some very interesting advances of what apparently are really quite simple. And when you think about them, you think, what an obvious point. But they weren't obvious before people did them. Simple things. For example, very important advance, what's called sentinel node sampling in breast cancer or melanoma. What happens in breast cancer and other cancers is the cancer spreads up the lymph nodes into the body. And what we used to do is remove all the lymph nodes, what's called lymph node clearing, which could lead to really significant side effects for women after they'd had the operation. But what they found is it's just as good to inject into the tumour a combination of a radioactive dye, which allows you to find the node, and then a bit of ordinary dye, which allows you to check you've actually got the right node. Remove that node, and if there's cancer cells in that node, then you carry on going. And if there aren't cancer cells, then that reassures you this cancer has not spread, and further very destructive surgery can be avoided. And this has been even further refined recently, and this is NICE approved, that we've now got tests for particular genes which can be done in 45 minutes. And that's important because it means you can do the sampling of the lymph node in the operation and then decide to continue or not in the operation rather than having to go back for a second operation a few days later. So these incremental advances have led to really quite substantial improvements on surgical outcomes, and most importantly, in many cases, making sure that people don't have damage due to surgery unnecessarily afterwards. The second form of treatment that was developed, and it was developed at a surprisingly early stage, was radiotherapy. It was first used for cancer in 1896, so over 100 years ago, and the initial way of doing it was to give a massive dose of X-rays. And the first big advance on this was actually in the 1920s, which found that radiotherapy you can give a whole series of very small doses, or relatively small doses, over time, which allow normal cells to recover, but the cancer cells recover more slowly. Engineers worked with this, and by the 1950s we had much more powerful machines, things called linear accelerators, which gave much more powerful X-rays, and these gave stronger X-rays, particularly gamma rays, and these penetrate further, which basically means they go through you if they don't hit the thing you want, rather than just stopping inside you, and they damage the skin less than some of the earlier, more weaker X-rays. And then over time, the beam has become more focused, so you can focus it on the area that you want and not damage areas that you don't want. So these have been engineering improvements over the last 100 years. And you can use radiotherapy for a variety of different things. You can use it as a standalone treatment for cancer. For some people, radiotherapy is the single treatment. Relatively rarely, but it certainly can be used. You can use it to shrink tumours before you do surgery. You can do it to reduce the risk of cancer coming back after surgery. So you do the surgery and then you do the radiotherapy to kill off any remaining cells. You can give it with chemotherapy, or in people who've got inoperable cancer, you can use it to control symptoms. So, for example, if they've got a back problem, a bit of back tumour, you can kill that off specifically to reduce really unpleasant pain at the end of life. So there are many ways radiotherapy can be used. And the basic principles of radiotherapy are relatively straightforward. Radiation damages DNA, which is the thing which allows your cells to propagate. It does this via free radicals, probably. And cancer cells, because they're constantly turning over, they're constantly dividing, are more sensitive, and they're also generally less able to repair their DNA, meaning that a damaged cell remains damaged and will die and not propagate. And normal tissues are less likely to die, and they're better able to repair themselves after this. So that's the basic principle. And what you do is you shine the radiotherapy into from several different angles, meaning that only the area with the tumour has got a very high concentration of the radio beam, and all the other areas have only got one of the three or maybe multiple beams, so therefore they have much smaller doses of effective radiation. So the aim is to concentrate fire in one place where the tumour is and have much, much lower amounts of radiation anywhere where the tumour is not. Very simple. Basically, anyone who has done arithmetic which involves working out how sort of various lines do or does navigation will understand the basic principles behind that. Now, the radiosensitivity of tumours varies quite a lot, and it varies due to a number of different factors. The first one is that large tumours are, for a variety of reasons, less radiosensitive than small tumours. And radiosensitive means likely to die with radiation. So you often want to shrink the tumour down or do surgery first so you don't have a very large tumour which is going to be less affected by the radiotherapy. Certain cells, and particularly ones that turn over very fast, such as lymphomas, leukemia, and the germ cell tumours, that's testicular cancer and ovarian cancer, are also very radiosensitive generally. So if you shine radiation at them, they're much more likely to die. Some, on the other hand, are very radio-resistant, in particular renal kidney tumours and melanoma. Kidney tumours are relatively rare. Melanoma is much more common. And you can sometimes give drugs which actually make a cell that wasn't radiosensitive subsequently. So drugs such as cisplatin would be ones that many people may have heard of. It also, of course, matters where they are. If you've got a very localized tumour, then firing radio beams from multiple angles at it is a relatively straightforward thing to do. You know where it is. If you've got a very widespread tumour, such as a leukemia, that's much more problematic, and I'll come back to that. And clearly, it is more difficult if you've got metastases of a tumour in lots of places in the body. So it is most useful where there's one or a small number of tumours which you can clearly identify, or in these radiosensitive ones. A lot of the advances in radiotherapy have been not so much about how you get the radiation to the place where the tumour is, but how you avoid getting radiation to the places where the tumour isn't. And there's now very sophisticated modelling done by computer, largely based on CT scans, which aim to get the optimal, meaning the high, dose to the area where the tumour is and minimise the amount elsewhere. And so what you have in this scale is areas of red are where there's going to be a very high concentration of radiotherapy because of the multiple beams hitting just in that place. Areas of blue, really not very much. And this is to try to hit the red optic nerve. This is a tumour of the optic nerve just behind the eye on the right in this case. Alongside better planning are machines which are substantially more accurate. And they're more accurate by a variety of different mechanisms. Some things are making life more accurate, quite simple things like doing molds, individual molds of people's faces, so you always get them exactly in the right place on the radiotherapy table. And some of them are things like these different things like proton beam therapy, which is a slightly different form of radiation, does broadly the same thing, but it penetrates less far and has less scatter, so you can be much more exact. The point about these tumours is particularly, these radiotherapy methods, is particularly if the tumour is in a vital organ, like the brain, this allows you to damage the tumour, but actually concentrate really hard only on the area where the tumour is going to be present and not damage anywhere else. That's really where many of the big advances have come. How about the side effects of this? And again, a lot of people kind of think of Hiroshima when they're talking about this and think they're going to be absolutely horrendous. Actually, for many people, for radiotherapy, side effects may be limited to temporary fatigue and localized skin redness, rather like this lady is demonstrating here, which looks rather like very bad sunburn. For the rest of the side effects of radiotherapy, because the radiotherapy doesn't go anywhere you don't want it to go, broadly, the side effects will be limited to where the radio beams were put. So if, for example, you're doing radio beams at radiotherapy to abdominal, brain or ear, you might get nausea, but you're unlikely to if it's going to places that aren't involved in digestion or in the way in which you feel nausea. Dry mouths tend to be very problematic in head and neck cancer. It sounds trivial. It's distinctly not if you've got it. And there is a problem of infertility sometimes in people quite frequently actually, in people who have radiotherapy that is in or near their pelvis. So the point about this is radiotherapy side effects are significant, but they are localized in general, with the exception of fatigue. The third modality of treatment, again, relatively old, is chemotherapy. And again, everyone in the audience will know about this. Chemotherapy agents have come from a very wide range of areas, almost all of them found by accident, not because we were looking for chemotherapy agents. The first ones were the nitrogen mustards, which came from mustard gas, used gassing in the First World War. And the first one from this group was cyclophosphamide, which some people in the audience may indeed have had. It's still very widely used. Then there was a lot of work discovering folate, an important vitamin, particularly in pregnant women, other areas as well, and as a side effect of that, drugs which interfere with the folate pathway, of which the most important, that's probably most widely used, is methotrexate, one of the earliest ones. There were drugs that were discovered when looking for anti-diabetic drugs, and they came from a variety of plants like this beautiful Madagascar periwinkle. And they gave us drugs like vincristine, vinblastine, which again are still very widely used. And then there were some that were just accidents. There was cisplatin, which was an accident of the effects of electrical fields on bacteria. The point about this is very few of these chemotherapy drugs were designed to be chemotherapy drugs. They were discovered and then accidentally found to have strong cytotoxic properties. Now, the thing about chemotherapy is that the basic mechanisms of it are very simple. It will kill, or it aims to kill, cells that are dividing. And because cancer cells are dividing uncontrollably the whole time, they are much more likely to be killed than normal cells, many of which are not dividing very frequently. So cancer cells, the chemotherapy will kill cells throughout your body, but it'll kill cancer cells differentially a lot more, but it will also tend to kill cells for bits of the body which are naturally dividing themselves, and I'll come back to that. The way they do this is by multiple different mechanisms. Some of them directly damage DNA, like cyclophosphamide. Some of them interfere with the DNA or RNA synthesis, like methotrexate. Some of them attack enzymes which allow DNA to replicate. And some of them interfere with some of the other cellular processes, like the microtubular system. So anybody who's recently done GCSE biology will recognize all of these processes. The point about cytotoxics is they attack all the way down the cell division process. Increasingly, over time, we moved from an era where we just used one cytotoxic drug to using several cytotoxic drugs, and these have a number of benefits. The first of which is it gets the best balance between toxicity and effect. The second is that it reduces the impact of resistance, because just as bacteria can develop resistance to antibiotics, so some tumours can develop resistance to a variety of chemical agents. And it also means you can combine them in a way which is particularly optimal for the tumour you're dealing with, and you can combine them with things like surgery. The thing with all of these is that generally each one of the changes we've seen as we've combined things has led to slightly better side effects or slightly better outcomes or a bit of both. None of these have tended to be dramatic breakthroughs, and much of the advances we've seen over the last few decades have been incremental, very, very small advances. So every year things get slightly better in the way we can actually use these agents. What everybody knows about chemotherapy is that it has bad side effects, and there's no two ways about it. Chemotherapy side effects can be awful, although the chemotherapy agents vary very substantially in which side effects you get and how bad they are. The biggest impact that you don't want, but you're going to get as a result of chemotherapy, is in cells which naturally are dividing rapidly themselves. And those in humans tend to be the gut, hair follicles, mouth, skin, and bone marrow. Those are naturally turning over very fast, so therefore they are naturally drugs which actually interfere with cell turnover are going to differentially affect. And so, not surprisingly, the big effects you tend to get: nausea and vomiting, swallowing because of the gullet, hair loss because of the hair follicles, and damage to the immune system, meaning that during treatment, your immune system is not working well and you're very susceptible sometimes, depends on which chemotherapy agent, but you're very susceptible to infection. So there are significant side effects, but they do vary. One treatment which then developed after chemotherapy was, particularly for the leukemias and lymphomas, bone marrow and stem cell transplant. If you've got something like a leukemia or a lymphoma, you can't just rely on the fact that there's a particular tumour in one place. It may well be spread very widely through the bone marrow or indeed through the blood and the blood system. And therefore, you will need to kill all the cells. You will need to irradiate or give chemotherapy to the whole body, essentially wiping out or near wiping out the bone marrow, and then you have to do something to replace it, because otherwise you won't get red cells, you won't get platelets, and you won't get white cells, the essence of all the things the blood does for you. And so what happens is people have the chemotherapy, which kills both the disease cells and the healthy cells, and are then given a stem cell which repopulates, or a bone marrow which repopulates the bone marrow they have. And they sometimes have it from their own stem cells, and sometimes they have it from donors. It depends on the condition they're being treated for. But this allows you to rebuild the immune system essentially from scratch. So those, I think, are the treatments which have most people think of when they think of cancer. I'm now going to move on to a group of treatments which are much newer and are broadly much more targeted on the tumour cells and are therefore, in general, like to cause many fewer side effects. And the first group are what are called small molecules. This is one of them. It's a very well-known one. Tyrosine kinase inhibitor, imitinib. Also goes under the trade name Gleevec. Now, this is a drug which was developed and works specifically, in other cancers as well, but specifically in a particular form of chronic leukemia, CML leukemia, chronic myeloid leukemia, which is what's called Philadelphia chromosome positive, which is the majority of these cancers. And this doesn't work by killing the cells through the nucleic acid like chemotherapy. This works by interfering with a protein which is essential for the tumour's life. And this protein drug combination only really majorly affects the tumour cells we're talking about. It's not present to any great degree in most other cells. So it's much more targeted on the cancer cells than other treatments. That had a dramatic effect on CML leukemia. So this single drug, and this is one of the relatively rare examples of a breakthrough in cancer. I'm very suspicious of breakthroughs, but this really was a breakthrough. It led to a situation where the great majority of people who had this cancer would die, to a situation where the great majority, 85% of people who had this cancer would survive. But, very important but, this is rather unlike chemotherapy or radiotherapy, this doesn't cure in the sense you take a course and then you stop. This is a long-term treatment. So this is more like treating diabetes. So these people will probably be on this drug for life. And a point I'll come back to at the end when I talk about policy, cost a very serious problem with this drug. Very expensive. Another big advance has been finding that quite a lot of cancers, but particularly breast cancer, prostate and ovarian cancer, have hormone drivers. And if you have a breast cancer, for example, which is estrogen receptor positive, so estrogen is one of the female hormones, well, it's a hormone for all of us, but it's one that's particularly women have. And if it's receptor positive for that, if you use a drug called tamoxifen and various drugs like it, which block that receptor, then your survival from breast cancer substantially improves. You take it for initially 5 years, and I think more recent data would suggest people need to take it for about 10 years. And this, by blocking the tumour drivers via hormones, will mean that the tumour just does not progress. So again, it's a long-term treatment, maybe not lifelong, but for very many years. And then new drugs have been developed, so tamoxifen particularly effective in people who are premenopausal. Then several drugs classes have been developed subsequently called the aromatase inhibitors, and they work by a rather different mechanism to reduce the amount of hormone in the body, and therefore by the same way they reduce breast cancer progression. So here you've got a situation where, because we reduce the driver of the cancer essentially remains quiet and doesn't progress on. You can't have any talk in the last 40 years without thinking about genetics, and in cancer, genetics is beginning to really make itself felt. There are some particular genetic cancer markers in people which demonstrate they have such a high risk of cancer, you actually need to take preventive action. This is a relatively rare situation, but a very recent and much publicised example was Angelina Jolie, who has a form of genetic marker which suggests she's highly likely to develop breast cancer, and she took prophylactic action on that. We're already in the situation where we have some genetic markers which are guiding our treatment, but this is likely to become increasingly important. And so what we will be able to do is tailor the cancer treatment to the particular genetic makeup of the cancer you have. And that is really the future of cancer treatment over the next 100 years. I think most people would agree. So that you find exactly what cancer someone has, not just that it's a melanoma, but it's a melanoma with this particular group of genetic changes, and then you aim at treatment which works specifically for that and is not going to affect other cells as much. And some examples of the kind of things that are happening in the UK is for the 100,000 Genomes Project, where we're attempting to look at genetic combinations of your normal cells, your cancer cells, and seeing what the difference is in a very large number of people. And over time, I think this field will advance very quickly. Breakthrough is an extremely easy headline. I've taken a cheap shot at some of the newspapers. I could have chosen any of them. And these kind of headlines sell, so that's why you see them. This is great newsworthiness. It's of relatively limited scientific accuracy. But the big area of advance, where if there is a breakthrough, I think many people think breakthroughs will come, is in what's called immunotherapy. The immune system is there to fight infections. I think everyone knows that. But it also fights cancer cells. It identifies abnormal cells of yours and locks onto them and kills them. By definition, therefore, a cancer which actually progresses to be a cancer is something which has evaded the immune system. Now, if the immune system can be allowed or trained to identify cells which are cancerous, it can then do the killing for you. Your own immune system can actually do the heavy lifting. And part of the immune system, which I'll come on to, antibodies, have particular uses. And this is really the most rapidly growing field in cancer treatment. Antibody treatment is used already. And antibody treatment is much, much simpler than immunotherapy, which I'll come on to. In antibody therapy, what you do is you design an antibody which will lock onto particular receptors on a cell surface in general, and either block them or stimulate something. And the one that is most widely used at the moment probably is a drug called Herceptin. Its trade name is Herceptin. This is a monoclonal antibody. It has a particular structure, and it locks onto receptors on some people's breast cancer. It only works in a minority, about 20-30%, and it significantly improves survival. So this is the first example of using an antibody to reduce the progression of disease by targeting a particular marker on the cell wall. This form of immunotherapy is relatively straightforward, and it is likely we will do a lot more of this over the next 2 to 3 decades. Slightly more speculative, or in fact considerably more speculative, but I think likely to happen to some degree, is the idea that you can attach onto an antibody either a drug or radiotherapy, so the antibody locks onto the cancer cells and delivers just to those cells the drug or the radiotherapy that you want. And this is, I think, again, the concept behind this is at least relatively simple to understand. I think the most exciting but the most difficult area is something called immune checkpoint blockade. And this one I will just pause on this slide because this is slightly harder science. The immune system is designed to kill abnormal cells and not to kill normal cells. Sounds easy, but not as easy as it sounds. To stop it killing normal cells, the cells have a system of signaling to one another that says, look, guys, I'm normal. Don't kill me. A kind of immunological handshake. If you can stop the cell from actually having the ability to recognize that, so many cancer cells have developed the ability to produce what's called a checkpoint inhibitor, a checkpoint system in them. And the checkpoint means that the cancer cell does this immunological handshake with the immune cell and tells it not to kill it. If you can turn off that system, block it in some way, then the cancer cell may be killed by the immune system. So you're taking the brakes off the immune system. And if the immune system has recognized the cancer cell, but it is being put off by this friendly signal, then it'll zero in and kill the cancer. But the danger is, of course, because you've taken the brakes off, it may also zero in and kill normal cells. So we have the first few drugs which are able to be immune checkpoint blockers. So the immune checkpoint, the things which actually stop the immune system attacking a cell, the blocker stops that blockade happening. And the results of those in a few patients have been absolutely spectacular. So this, for example, this is from the BBC website, so many of you may have seen this series, is on the left a gentleman who had melanoma. He had the immune blockade, and on the right is what happened after he'd actually had this treatment. The immune system had destroyed the melanoma that was not amenable to other treatment. Extraordinary effect. The problem is that some people who have this have remarkable effects on their cancer, and some people have really dangerous effects because the immune system goes rogue and turns on everything else in the body. So what we've got to do is be able to get the immune system to be much more targeted just on the cancers. And what I suspect we will end up with, most people think we'll end up with, is some combination of immune checkpoint blockers to take off the brakes and vaccines to tell the immune system which cells you actually want them to attack. This, I think, is likely to be a major advance. If you look backwards from 50 years out, it is likely to be in this area that many of the biggest advances are seen. Now, there are, unfortunately, some very serious policy issues with this. There's going to be an enormous slew of incredibly interesting, exciting new cancer drugs over the next 20 years. Most of them are used initially only in terminal cases. And the reason for that is that if you've got a new drug and you've got someone who's dying because no other cure works, you're prepared to take a chance on that drug, even though it may have side effects you're not expecting, and you sort of try it in those people. But these drugs, therefore, often only extend life by a few months, and they are cripplingly, some of them, expensive. So this is a graph showing how purchasing power parity, in terms of the average costs normalized to 2013 costs. So this isn't inflation. This is the cost of a life year with modern drugs over the last 2 decades. And what you can see is that if you take away the effects of inflation, it has got a life year in terms of drug costs has gone from about $50,000 to about $250,000. Now, this is in the US, and drug costs here are different, but it's just demonstrating this enormous inflation in the cost of the drugs to save one life or to improve things by 1 year. Now, for an individual and their family, these months are absolutely priceless. So there's no doubt at an individual level you would want to give these drugs. But societally, in a system which is actually cash limited, you've got a health budget, that's the budget you've got, any money put on this is money taken off another health priority. And if there's just 1 or 2 drugs for rare diseases, this is not likely to be a big problem. If you've got multiple drugs for very common diseases, this is going to cause a very serious bit of concern. And we need to think about this as a society really quite carefully. Much more important, however, in reality, than new drugs which prolong life by a few years is early diagnosis. Because with early diagnosis, you can do usually simple treatments that are much less damaging and are much more likely to be effective. I'm not going to go through the diagnostic pathway in any detail, but the point about this is it can fail all the way down from the point of someone not recognizing they have symptoms, being persuaded by their husband or wife, don't bother the doctor not spotting the symptoms are important, or referring on to the wrong person because the right person's away, diagnosis fails. A whole series of things can happen, each one of which is small, but the cumulative effect can be to delay cancer diagnosis, and that will lead to avoidable deaths. So improving this pathway at every stage is really the key, I think, to many of the advances we will see in the next few years. The one which is the easiest to do is screening. Easiest in the sense that it is relatively mechanistic. And an example of a screening system that we think is effective, for example, is in breast cancer screening. The benefit of breast cancer screening is that with X-rays you can catch the cancer early. The risks, of course, are you overdiagnose, so you pick up things that look like cancers but aren't, remove them, someone has unnecessary surgery and over-treatment. And you can occasionally give people false reassurance because you do the test, it appears normal, but actually it's not correctly, not normal at all. It is felt, however, going through all the data, that the breast cancer screening system here in the UK and in many other countries is effective in people above roughly the age of 50. Under that age, it probably is much less effective. And in England, the estimate is that we detect about 8 cases of cancer for every 1,000 women screened over their lifetime. So this is quite significant numbers. Exact numbers are very difficult to come by. But let us take prostate cancer, another major cancer. Very big studies of this have randomized people to screening or no screening, and what they have demonstrated is that there is absolutely no effect of screening at all. All the trials, we put them together, hundreds of thousands of people, no effect. So prostate cancer screening actually is not effective. And if you look across all of the different cancers, for some of them screening will be beneficial, for some of them it will be useless, and for some of them it will be actively dangerous because it will overdiagnose people who don't actually have cancer. So screening is not a panacea. As our diagnosis gets better, the risk-benefit may improve towards screening. So screening, the fact that prostate cancer screening with modern technology doesn't work, doesn't mean it would not with technologies we will have in 20 years' time. But at this point in time, that's where we are. A bit about palliative care, just really to make a single, simple point. When people hear palliative care, what they think is you're going to a hospice and you're going to die. Palliative care is simply the way of reducing the symptoms which come as a result of treatment and of the disease. And you should be having palliative care if you have cancer, unless it is really small and removed by a small surgical procedure all the way through. It's to reduce nausea, to reduce pain, to reduce other unpleasant symptoms. Palliative care is really just about symptomatic treatment. Last 2 or 3 slides. How does the UK compare to the EU and other countries with developed health services? Well, the reality, I'm afraid, is that we are neither the best, nor, despite some headlines in some newspapers, the worst. We're about average for the EU. Some cancers were better than average, some cancers were less good. One of the things that is problematic is that the debates about this all tend to zero in on these very expensive drugs that are only used in the terminal phases of life. Actually, the big wins are going to be in improving early diagnosis. That is the key to us improving our cancer survival with existing technologies. So, to summarize, first, this slide really just making the point that if you think about breast cancer, if you think about this remarkable, in my view, improvement from 40% survival in the 1970s through to around 80% survival now, no breakthrough caused this. It's caused by a combination of better diagnosis, a screening program, surgical advances, which have meant that we're better at getting the margins and not damaging other things, better radiotherapy, better chemotherapy. This is just incremental advances. Hormonal treatment, probably the most important single advance, with tamoxifen and other drugs, and antibody treatments, more recently in a minority. So no one thing caused this, multiple small things do. And the advances we will see in the next 20 years will be much the same. So considering treatment for cancer. Treatments for most cancers are much more effective and much less harmful than are actually popularly imagined. Most people think both the treatment will be worse and their prognosis is worse than it actually is. They have steadily improved over the last 40 years, and I'm absolutely confident they will steadily improve over the next 40 because the line of improvement is basically a straight line and has been for all of these cancers. There's no sign these are flattening out. Many cancers, which currently are causing a lot of mortality or morbidity, are going to become either curable or chronic diseases like diabetes. But it must be stressed that cancer treatment, even the newer ones, will never be easy. And so cancer is, above any other disease, in my view, a disease where prevention is better than cure. And that will be the subject of my next talk. Thank you very much.